Good afternoon, everyone. Thank you very much to the organizing committee for the invitation. My job today in the next 25 minutes or so is to cover the role interventional radiology plays in the management of hepatocellular carcinoma. These are my disclosures. So very quickly, what we are going to talk about, and this is a conversation that can happen over days in terms of getting into the weeds of the data behind different modalities and the treatments that IR offer for the management of HCC. But at least my aim is to give you an evidence-based approach on how to manage patients with HCC based on the current level of evidence that is out there. But by no means, again, this is a comprehensive review of all the different modalities that we can play a role in for the management of HCC patients. What I'm not going to cover is the pathogenesis of HCC. That is also an extensive conversation, and the risk factors and different underlying disease that lead to HCC and the variations in different parts of the world. However, we're going to briefly talk about BCLC staging, which is a very unique staging system that is used by many centers and in many countries, both Western countries as well as Eastern countries, which the uniqueness of BCLC staging is that it takes into account not only the tumor burden, but also the underlying liver disease and the underlying health of the liver to decide what treatment modality to offer to these patients. Because one of the biggest complexity of dealing with patients with HCC, for the most part, is that they have two diseases that you have to deal with. It is the underlying cirrhosis or chronic liver disease that has led to HCC, and then the tumor burden in HCC and how extensive it is. So the combination of two becomes quite challenging in terms of making the best decision-making for those patients. This is just a simplified approach to how BCLC staging works. Again, the uniqueness of it is that it takes into account the underlying liver disease as well as the tumor burden. For example, if somebody has a small tumor but very poor very poor liver function, a Child-Pugh C patient, and if they're not a liver transplant candidate, then based on BCLC staging, you should not treat those patients, because the mortality for those patients is dictated not by the tumor burden, but by the underlying liver disease itself. Again, we're not going to delve into that much, but I wanted you to be aware of the staging. So when it comes to the treatment modalities that are available for HCC, there are multiple curative and palliative treatment modalities that are available, and IR plays a major role in many of them. We're going to cover some of those. We will start with liver transplantation, which is a surgical approach, obviously, but a key component in the liver transplantation is either downstaging these patients to transplant criteria, as I will show you, or keeping them within the transplant criteria. And either of those would require a treatment by generally interventional radiology to make sure that the HCC tumors are treated while the patient is waiting to go on to get the transplantation. And then the actual treatments that we take part in are ablations, which could be percutaneous or intraoperative, generally either RFA or microwave, bland embolization, chemoembolization, which could be conventional or drug-eluting, and radioembolization. And we will go through each one of these. And again, I will show you some of the highest level of evidence behind each one of these. So the treatment decision-making becomes quite complex again with HCC, because of the fact that you're not only dealing with cancer, but you're dealing with a very sick liver in the most part. And you have to kind of have a balancing act of how aggressive you want to be to treat the cancer while not causing worsening of liver function. And multitude of evidence have shown, because of this complexity, that the best approach to decide on what treatment these patients should get should be through a multidisciplinary tumor board, and that has shown to actually improve outcome in terms of survival for these patients once they go through the tumor board, as opposed to decisions that are made by a surgeon alone, an interventional radiologist alone, or a hepatologist alone. Just like any other treatment, patient selection is key, and each of these modalities have different selections to kind of abide by, and there are different institutional variations between these selections and different societal variations. Again, that is beyond the scope of this talk. I'm not going to delve much into that. But you should be aware that basically, just like any other cancer treatment, patient selection will dictate how successful your outcome will be afterwards. Let's start with liver transplantation. As I mentioned, IR plays a key role in patients getting to transplant. It is the most definitive treatment option that we have for patients with HCC, because not only you take care of the tumor, you take care of the underlying unhealthy liver as well. It's a great option for early stage HCC patients that are not necessarily a surgical resection candidate. HCC is now the leading indication for liver transplantation in the United States and many other parts of the world. This is the Milan criteria that I previously alluded to, that patients and the centers abide by in order to get patients with HCC to transplantation. It is a single tumor of less than 5 centimeters or up to 3 tumors, with none of them exceeding greater than 3 centimeters in size, in the absence of vascular invasion or extrahepatic spread. There is a new variation with a more liberal kind of criteria called UCSF criteria, which goes beyond Milan criteria, with a single tumor of greater than less than 6.5 centimeters instead of the 5 centimeter, and up to 3 lesions, with none of them exceeding greater than 4.5 centimeter. Again, in the absence of vascular invasion or extrahepatic disease. So if a patient comes with UCSF criteria, data has shown that once you downstage them into Milan criteria, the outcome post-transplant in terms of survival is actually equal between the two, with 5-year survivals for patients within Milan criteria greater than 70%, and 5-year survivals for patients that were within UCSF criteria who were downstage into Milan criteria greater than 80%. And again, where IR plays a key role in both of these scenarios is if you're outside of Milan criteria, by a form of one of these liver-directed therapies, being ablation or some form of embolization, you can basically downstage the tumor in terms of the size and burden into within Milan criteria. Or if you are within Milan criteria, you keep them within Milan criteria while the patient waits for generally 6 to 9 months at least, and at some parts of the country much longer, depending on organ availability, to get them to transplantation successfully. Here is one of the early studies which actually started the conversation of the importance of bridging to transplantation. This was out of Emory. We looked at 205 patients that underwent liver transplantation. About 60% of them underwent bridging therapy, meaning one of these liver-directed therapies prior to liver transplantation. These were all patients with HCC, and 40% or so of them did not. What we showed was that the recurrence rate after they got the new transplant, meaning they got the new liver, and the transplant was significantly lower in those that actually received bridging therapy versus the ones that didn't, 3.6% versus 7.4%. So about twice as many recurrences if you did not get bridging therapy. But more importantly, the survival, both from the time of diagnosis of HCC and also from the time of liver transplant, were significantly prolonged if the bridging treatment was received prior to transplantation. Another study more recently out of Northwestern looked at 207 patients that underwent bridging with Y90 radioembolization. Our study out of Emory, we had a combination of ablation, TACE, and Y90 radioembolization. This study out of Northwestern specifically looked at radioembolization. Some majority of the patients were within Milan criteria, so they were bridged, and a smaller minority were outside of Milan but were successfully downstage to within Milan criteria, and then they got their transplant. They looked at the percentage pathologic necrosis within the tumor that were treated or the tumors that were treated, and they showed a different variation from about 50% or 45% of patients having complete pathologic necrosis to others having extensive or partial. And the important conclusion or the illustration of this study was that actually the amount of pathologic necrosis or how successfully you treated these patients with radioembolization dictated how likely it was to actually have tumor recurrence after the transplant was received, from 2% in those that had complete response all the way to 34% in those that had partial response. And these recurrence after liver transplantation is a significant problem. So the more you can do to actually reduce the recurrence rate, the better. So that's kind of where the two important studies that I thought I should share with you on how IR can play a role even in a patient that is undergoing liver transplantation. Very quickly, because we want to compare the efficacy of liver resection to percutaneous ablation, let's talk about liver resection. It is recommended because of the scarcity of organs for patients that have no evidence of portal hypertension and have small burden HCC. The recommendation is liver resection. Unfortunately, even though it is potentially curative, only 10 to 15% of patients, at least in the United States, are eligible based on the underlying liver disease that they usually present with. And a bigger problem is up to 60% of patients that undergo liver resection will end up with recurrence elsewhere in the liver. So even though the tumor is generally successfully resected, there will be other tumors within the liver that pop up later on, and that is one of the limitations or the biggest limitation of liver resection. So now let's talk about ablation, which could also potentially be curative for early stage HCC, similar to liver resection. Generally, the two most common ablation modalities that are used in the liver are radiofrequency ablation and microwave ablation. Microwave is a newer technology with a more uniform and larger burn zone, which has basically become the go-to ablation modality in almost all centers in the United States, at least. The idea behind ablation, whether RFA or microwave, is that once you achieve greater than 60 centigrade within the tumor bed, it actually is cytotoxic to all the tumor cells. So you can actually kill the cells. And historically, it has been used for tumors of less than 3 to 4 centimeter, but with combination modalities of chemoembolization and ablation, some people have successfully treated tumors even greater than 5 centimeters. Let's look at an important study that was published in 2010 comparing RFA versus surgical resection for small HCCs within Milan criteria. No difference in the clinical or demographic characteristics of the two arms of the study. 230 patients, the overall survival, recurrence-free survival, 5-year recurrence-free survival, and overall recurrence rate at 5 years all favor significantly towards the surgical group versus the RFA group, meaning that basically the oncologic outcome as a whole, whether it was survival or recurrence-free survival, was significantly better for the surgical group. These are some Kaplan-Meier curves looking at that, and that held true even for small HCCs that were less than 3 centimeters. Still in that cohort, the survival rate was significantly better in the surgical group versus the RFA group. And this study really swayed the conversation towards more surgical resection if patients were surgical resection candidates compared to RFA because of the limitations of the technology with RFA. But as I said, microwave, at least technologically, is more advantageous to RFA because you get better burn and more uniform distribution. And that is evident by the study that I'm about to share with you. This was a study looking at microwave ablation versus surgical resection for HCCs, again, with in-Milan criteria, so small HCCs. No difference in the patient characteristics between the two cohorts. In this study, the survival rates at 1, 3, and 5 years were actually similar between the microwave cohort and the surgical cohort, but the disease-free survival, meaning the recurrence rate, was marginally better and statistically significant, but not as significant of a gap as we saw in the RFA study that I showed you previously, in the favor of the surgical group, again, compared to the microwave ablation group. However, when they looked at specifically the HCC smaller than 3 centimeters, both overall survival and recurrence free survival were actually statistically similar between the two. So showing that actually microwave in HCCs of smaller than 3 centimeters, if done appropriately, can rival surgery in terms of the oncologic outcomes. However, when they looked at patients that were between 3 and 5 centimeters, although the overall survival was again similar, the recurrence-free survival was significantly better in the favor of surgical resection versus microwave. And this was a systematic review and meta-analysis comparing microwave ablation versus RFA, multiple studies. 4 of them were randomized control trials, head-to-head studies, 10 cohort studies. The summary of the study was that there was no significant difference in terms of disease response or tumor response, as well as the oncologic outcomes. The only difference they found was that in the laparoscopic microwave ablation versus RFA, the tumor recurrence rate was lower in the microwave ablation, and the toxicity and the complications trended towards significance in the microwave ablation arm. So that's what I wanted to kind of, based on the evidence that is out there, cover for the ablation part of things. Generally, microwave ablation is favored compared to RFA because of the data that I showed you and the ease of using microwave ablation compared to RFA, which is beyond the scope of this particular talk. Now let's focus on the intra-arterial therapies. There are 3 main intra-arterial therapies that are out there: conventional chemoembolization, drug-eluting beads chemoembolization, and Y90 radioembolization. The concept behind intra-arterial therapies in the liver, in general, and specifically for liver tumors, is the fact that basically the tumors receive about 80% of their blood supplies through hepatic arteries, whereas normal liver receives about 80% of their blood supply through portal vein. So you can embolize hepatic arteries generally without any significant toxicity to the liver. So let's talk about conventional chemoembolization. It is basically there are various chemotherapies that can be mixed with Lepidol. The ones that have been published on are generally doxorubicin, mitomycin, and cisplatin in the setting of HCC. the recommendation for BCLC-B patients, there's level 1 evidence that it has significantly improved survival compared to best supportive care, but it's also shown great efficacy for BCLC-A and BCLC-C patients. The way it works is basically you create this emulsified liquid, a very thick liquid form of chemotherapy that you inject into the hepatic artery. It actually crosses the arterioles and the sinusoids into the venules, which the proponents of chemoembolization or conventional chemoembolization always point out that this is one of the biggest advantage of this particular treatment compared to drug-eluting beads, which would not have the ability to penetrate this deep. And then you embolize the feeding artery where you did your conventional chemoembolization with some gel foam or bland embo to make sure that these liquids are not washed away through the arterioles and the sinusoids into the venous side of things. So this was a study that there were two major studies, one out of Asia and one out of Europe that really put chemoembolization on the map. This was out of Asia, 80 patients with unresectable HCC, 40 of them had TACE and 40 had basically symptomatic control or best supportive care. They were all BCLC-B or C, no main portal vein thrombosis. The TACE component of it, or the chemo component of it, was cisplatin and Lapidol, followed by gel foam. They showed significant survival benefit for the chemoembolization group versus the control group, with the relative risk of death of 0.49. So this was one of the body of evidence that actually significantly put chemoembolization on the map as one of the viable treatments for HCC. There were complications with TACE, fever, abdominal pain, vomiting, ascites, and GI bleed, but they were all transient. So that was the Asian study. The European study was out of Spain. They had 3 arms, a randomized control. One arm was bland embolization, the other arm was chemoembolization, the third arm was control. All unresectable BCLC-B patients. I'm not going to go through the exclusion criteria, but suffices to say that the study was actually stopped after interim data analysis because of significant survival improvement in the chemo group compared to the control arm. These are the data behind the survival. We don't have to go through all of that. The log rank analysis and the Kaplan-Meier showed significant survival benefit for the chemoembolization group compared to the control group. Now, so that was the data for, again, not extensive, brief data on why chemoembolization became one of the most commonly used treatments or conventional chemoembolization in the setting of HCC. Now, let's switch gear and talk about DEPTase. It's a newer technology compared to CTACE. The doxorubicin, which is the most commonly used chemoembolic material or chemotherapeutic portion of the chemoembolic material, is instead of mixing it with Lapidol or emulsifying it in this liquid form, they're loaded in these beads that you can see here, anywhere from 70 microns to 300 microns. Multiple studies have shown smaller beads to be more efficacious compared to the larger beads. It aims to enhance local delivery of chemotherapeutic agent with reducing systemic availability of the chemotherapy compared to a conventional TACE. Precision 5 study was an important study that actually showed that DEPTase had less toxicity compared to CTACE, and some marginal improvement in outcome, which we'll point out. The primary endpoint was tumor response. The secondary endpoint was toxicity. Objective response and disease control were similar between the two. However, when you looked at the advanced stage patients, Child-Pugh-B patients, actually DEPTase was a little bit better, both in the objective response as well as the conventional chemoembolization, as well as the disease control compared to the conventional chemoembolization group. And in terms of the toxicity, the serious liver toxicities were significantly lower in deptase group compared to the conventional chemoembolization group, and the systemic toxicities were actually better again in the deptase group compared to the chemoembolization group. For example, alopecia was only 2.2% in the deptase group versus 19.4% in the conventional group, and the cardiac dysfunction significantly better in the deptase group compared to the conventional group, because of the fact that there was very little systemic circulation of doxorubicin in the deptase arm. So in terms of the efficacy of deptase versus ctase, there's no head-to-head randomized control study that has clearly shown a superiority of one versus another. Many studies have shown that deptase has lower toxicity and some marginal improved treatment response in the advanced group, but all comparative studies have suffered from small cohorts. So it's hard to kind of make that conclusion. The best we can do is to look at some meta-analysis. This was a meta-analysis of 424 deptase versus patients versus 442 ctase patients, again, comparing objective response, survival, and adverse events. The objective response favored deptase with more complete response. But when you actually looked at the complete response favored deptase. But when you looked at objective response, which was complete response and partial response, actually there was no difference between the two. Overall survival favored deptase again. Adverse events favored deptase. Serious adverse events, there was no difference between the two. So with all that I've shown you, deptase generally has lower toxicity, potentially improved survival in more advanced disease, but it's not ideal for patients with large tumor thrombus, whereas actually ctase is more preferred because it is less embolic. And finally, in terms of the embolizations that are not radiation-based, bland embolization is also a viable option, although theoretically, chemoembolization should be more effective, but at least the current level of evidence shows no difference between the two. This was a study out of Memorial Sloan Kettering looking at, it was a randomized control trial looking at bland embol versus deptase in patients with BCLC A, B, or C. They looked at response rate, progression-free survival, overall survival, and adverse events. They basically showed no difference in any of those between the bland embolization versus drug-eluting beads transarterial chemoembolization. So between deptase and bland embol, neither wins. And even the meta-analysis of 5 randomized control trials had showed no difference between the two. Finally, and I know I've gone over time, radioembolization, I'm not sure about the availability of radioembolization in Armenia, but it is a newer form of technology that we use for treatment of liver cancers. Basically, instead of the microspheres eluded with chemo, in this case of deptase, they are either under surface or within the microsphere. There are radioactive materials, and the one that is most commonly used around the world is yttrium-90 or Y90. Although we started using Y90 radioembolization in more advanced disease, we are actually we are now using Y90 radioembolization for all stages, from very early stage in the setting of radiation segmentectomy with small HCC to very advanced BCLC patients. The idea behind it is that it basically gives radiation to the tumor at a very long half-life. The half-life of Y90 radioembolization is 64.1 hours, and you can deliver very high doses of radiation. But because it is beta radiation, it is at a very short range. So you can deliver very high doses to the tumor and surrounding area without causing toxicity to the remainder of the liver or critical organs around it. The mean penetration dose is 2.5 millimeter, maximum penetration dose of 11 millimeter. There are two products on the market with significant differences, glass microspheres or TheraSphere and resin microsphere or SurSphere. I'm not going to bore you with a lot of this detail. In the interest of time, I'm going to stop here, and hopefully this kind of gave you a brief overview of the data that is out there. I'm just going to say that multiple studies have compared chemoembolization to Y90 radioembolization. Many of them have shown equivalency in terms of the response rate as well as survival, with better progression-free survival for the patients that have undergone Y90 radioembolization. But a recent study out of Belgium actually showed significant survival benefit for Y90 radioembolization compared to chemoembolization. And another point to consider that has significantly improved the data in terms of the contemporary studies that have been published on Y90 radioembolization is the concept of dosimetry and personalized dosimetry. So with that in mind, and again, not proven with the exception of one study, but the consensus, if you ask people that have availability of all modalities in terms of the intraarterial ones, people think that if you do personalized dosimetry with Y90 radioembolization, you can probably get better outcome compared to chemoembolization. I'm going to stop sharing. Thank you very much for your attention. And unfortunately, I won't be available in personally answering any of your questions because I'm traveling, but please, if you have any questions, feel free to email me and I'm more than happy to answer any of your questions. Thank you very much.